Okay, we'll get rolling then. So welcome back everyone to the next instalment of 2022's State of Play, and also welcome to any new viewers we have for tonight. Firstly, I'd just like to give an acknowledgement of country. So in the spirit of reconciliation, we acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. Pay our respect to their elders past, present and future, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. And I'd like to acknowledge the Wiradjuri people on whose land I am and pay my respects to elders past, present and future. So for you, those of you who haven't participated before, State of Play is just an opportunity for you to hear directly from our world-class M&D researchers here in Australia. And many of these researchers have been supported either previously or currently through M&D Australia funding. Tonight, we have two researchers who are working right at the applied end of the research spectrum. They are allied health practitioners that obviously work directly with patients. So a little different to perhaps some of the lab presentations we've heard from previously. So tonight we have Karen Hutchinson from Macquarie, who is a physiotherapist and an implementation scientist. And we have Salma Charania, who is a speech pathologist who works with MND Queensland. Salma recently completed her PhD, actually only just back in April. So we'll be hearing from about her PhD studies tonight. So you also may have seen a pop-up message about recording the session. Just click OK and it will disappear. We record the sessions for you to watch them again if you wish, or obviously people who've registered but weren't able to make it tonight. Each of our speakers will speak for about 20 minutes, and then we'll have a combined Q&A session following both our speakers. Please feel free to fire any questions you have using either the chat or the Q&A function in Zoom, or if you're on Facebook, please use the Facebook function, and we'll collate all the questions and ask them in the Q&A session at the end of the session. I think that's enough from me for tonight. So first up, we're going to hear from Karen. Take it away, please, Karen.
Thank you. I'll just share my screen. Hopefully everybody can see that.
That's all good, Karen.
Okay, thank you. I think just like to thank you for the opportunity to present tonight. Firstly, I'd like to acknowledge the Darkinjung young people as traditional custodians of the land in which I'm presenting from. I pay my respects to the elders past, present and future, and I extend this respect to any Aboriginal people who are here today. Firstly, I'd like to just introduce myself as a research clinician. As Gethin has already mentioned, I've been a physiotherapist for many years with a clinical focus on the management of people with neurological conditions. As a physiotherapist, I've also been involved in co-designing, developing and implementing community-based neurological multidisciplinary teams, both in the UK and Australia. And currently, as a researcher, I conduct healthcare research with a particular focus on integrated models of care and implementation science, so translating evidence into practice. I'd like to acknowledge the wonderful research team involved in this MND research on the Central Coast that we'll mention today. So there's Dr. Anna Schutz, who's the Central Coast neurologist who set up the team. Professor Nick Goodwin, who is the director of the Central Coast Research Institute in Integrated Care, Dr. Anne Hogden, a researcher in the area of MND and a lecturer, and Dr. Sally Carr, who's the director of palliative care on the Central Coast. So basically, just a little overview just to guide you through the talk today. So we're just going to talk a bit about services and support for MND, regional-based multidisciplinary clinic that's been set up and the evaluation process that's being involved with that. Some preliminary findings of a review of evidence on integrated models of care in MND, and just a brief overview of some of the physiotherapy and exercise prescription in MND, just a bit of an update on that as well. So we are covering quite a few things. So as everyone is aware, it takes a team working together with people living with motor neuron disease and their families to provide care and support specific to needs and their priorities. So I'm sure that isn't anything new to anyone there. So just some background, what do we know? It is important that all services and care is focused on the individual and family needs and values, and integrated through supporting what we call like joined up care across different organizations and sectors. So person-centered care for people living with motor neuron disease is challenged at all levels of healthcare by the disease trajectory, the person's experiences, and sometimes inequities within and between health systems and services. However, there is a challenge with the current funding models that some people may be experiencing, which is based on age rather than diagnosis, which is particular for people living with MND over 65. So this can actually impact the equity of care that people are experiencing. So specialized motor neuron disease clinics can provide optimal approach to receiving and coordinating quality care, but what has been identified is that most are based in cities, therefore not always accessible to everyone. However, this is probably changing with the more access to telehealth across the health sector. So for some of you, you may already be aware of the NICE guidelines, which is the National Institute of Health and Care Excellence UK guidelines, which are based on the best evidence. And this is a sample of those related to organisation of care, which identifies coordinated care, specialist MND, multidisciplinary team approach. Again, multidisciplinary team is highlighted throughout all of this. But also includes healthcare professionals and social care. And for the people should have access to care in their home, effective communication and coordination, and sort of frequent visits. Usually they recommend 2 to 3 months. And the multidisciplinary team should assess and manage and review specific areas and the person's response to that. So who is involved in care and support? So this diagram looks rather busy, lots of colour, and it's certainly not a complete picture, but it gives a sense of who is part of the team providing care and support, with the person living with MND and their family members central in all of this. But this large team works across different organisations and sectors, which can make it difficult to communicate and coordinate, despite everyone working towards the person's goals and needs. So the specialised motor neuron disease clinics, which I have got a yellow magnifying glass, can help support connecting the care. And it is a central place where people can go and communicate, and from there they can communicate out into the places where you may get usual care in the community that you live. And communication is very important throughout. And it's also, the clinics can be used as a way of sharing of knowledge and understanding of motor neuron disease with other healthcare professionals who may not have had much experience in that area. I've also highlighted physiotherapist as well as being one member of the allied health team, but you can see that, there is a lot of people involved in supporting people living with MND. So we talk about this being integrated, and what does that mean? So what is integrated care and why is it important? So integrated care has been highlighted. It means different things to different people, but it's about getting the right care at the right time in the right place. So it helps to overcome fragmentation of care delivery, to coordinate care centered on your needs. Integrated care is an approach to improve quality and cost effectiveness of care. And it's also person focused, and it to provide services related to individual, the family, caregivers, and the wider community that people belong. So to address the current fragmentation of care and distance to specialised clinics, a regional-based multidisciplinary clinic was set up on the Central Coast. For those that don't live in New South Wales, I've sort of provided a map to give you an idea where this is. So we're about an hour and a half north of Sydney, and it is quite an extensive area. So we have approximately 43 people living with MND on the Central Coast. We've currently held 7 clinics, and if you note, it started actually just at the beginning of the pandemic in February 2020. So the clinics we have 3 clinics a year. There's a total of 21 people have attended, and the mean age is 67 years. And not surprisingly, there's been a smaller number of females to males. And also I wanted to note the 6 people that attended get NDIS funding, 13 My Aged Care, 1 was DVA, and 1 reported no funding. So how does the current clinic function? So the person who gets referred by their neurologist, to the clinic, and they are sent a letter of introduction and an appointment. So when they attend the clinic, they can there is an option to attend via telehealth, and the family members or carers are encouraged to attend. When they attend the clinic, the person sits in a room, and the therapists and the medical team all come to that person while they sit in that one room. The team that's involved, that's actually there in person, are the physiotherapist, the occupational therapist, there's a nurse, occasionally a rehab specialist, dietitian, speech pathologist, and a neurologist. And as I've sort of highlighted in green, where actually got specific carer support is about to be initiated, which has been an identified need that we currently didn't have. Then the person is then returns home, and we have a case conference where we include video conferencing with a respiratory specialist, a palliative care specialist, and if the MND advisor or care coordinator of support are not there in person, then they will attend via video conferencing. And then what happens from the case conference is then we have identified goals, and we then relay and communicate those to the appropriate healthcare professionals that are involved in their care. And there may be referrals to palliative care or respiratory team or gastroenterologist, whatever, depending on what their needs are. So we were very lucky to get a small amount of funding, so we were able to evaluate the clinic, and the idea was to evaluate the role and the impact of this clinic, which actually connects with healthcare professionals across health and within the private sector, the not-for-profit organisations. So we, and through primary care. So we're trying to sort of work out and speak to different people to get their perspectives on how the clinic is functioning. We want to also examine the barriers and enablers to the implementation and sustainability of the clinic. So currently this clinic is not funded and is being held in a private clinic on the Central Coast. We want to be able to gather information to inform design and development of other regional MND clinics. Now, for those, you might be wondering what this quadruple aim is at the side. And the quadruple aim has been adopted as a set of principles for health system reform across the world. And it is important in the evaluation that we get perspectives from everyone involved and consider this, the quadruple aim. Oh, excuse me, sorry, gone the wrong way. So what research, how are we doing the research? So we've got, it's a mixed methods design study. So we're conducting interviews with people living with MND, family members, and the healthcare professionals that attend the clinic. So we are conducting these interviews in person or via video conferencing, whatever suits, and adapting to the technology needs of anybody living with MND. We're also conducting a red cap survey, which will be distributed to the health and social care providers who actually receive the communications post-clinic to actually identify if we are addressing any of their needs in sharing information and connecting care. So we're using the analysis to analyze the barriers and facilitators. We're using what's called the theoretical domains framework, which helps to work on identify the influences on healthcare professionals' behaviours related to implementation of evidence-based practice. And then we're also going to do evaluate using the re-aim, which looks at the reach into the target population, effectiveness of the clinic, adoption again of the staff using the clinic and other areas who are referring into the clinic, and the implementation, looking at the consistency and cost of delivery of intervention, and the maintenance, which again is the sustainability of this clinic. Within this study as well, where there is a need to identify the current evidence on recommended and or implemented models of or elements of models of integrated care specific to MND. So we are trying to work on a framework providing focus and purpose for this review. So looking at the setting, the perspectives, interventions, and also evaluation. There isn't really currently not too much comparison, but we will identify any of those. So currently the rapid review that's being conducted is highlighting a lot of information around multidisciplinary clinics and multidisciplinary care. There is an increase in patient perspectives, people that are using the services, getting them involved in the development of clinics. What do people want? So what the literature says about these integrated models of care, and for quite a few people, this is no surprise. So the coordinated, integrated, interprofessional care improves health outcomes, improves resources used, greater satisfaction with care for the users and the providers, improves survival in MND, which includes timely access to respiratory support and gastrostomy, and that's often related to the non-invasive ventilation use with the respiratory support, and that being supported in the community. The inclusion of palliative care services, there's improved communication across organisations and sectors, and there's more links with community-based non-invasive ventilation and mechanical ventilation teams. Some things that we need to consider as the distance to specialised MND clinics can be a barrier, but telehealth technologies make this more accessible. Multidisciplinary teams need to consider stage and duration of the person with MND, and the person living with MND's expectations, needs and priorities. And I know from my physio experience, some people have, that is definitely something that people have spoken to me about when they've attended some clinics, the distance and the effort that's involved. And also that there is education opportunities for people living with MND, families, health and social care providers in this space. So just briefly, as I'm a physiotherapist, just to outline some of the things, the areas that we consider when people come to the clinic or when we're seeing people in their homes or in the hospital system. We assess and maintain function and manage physical changes. So we're looking at mobility, transfers, balance, posture. I've highlighted exercise prescription because I was just going to provide a little bit more information on that. We're looking at chest management, like managing pain, the prescription of mobility aids, splints, collars, and falls prevention. So physiotherapists work across a range of settings, and some work as part of a team and other work as private practitioners. And this has been probably more so since the introduction of the NDIS. And that has been a highlighted concern with the allied health team, is there's less linking with other healthcare professionals working as a private practitioner. So that within the therapeutic exercise for people living with MND, what does the research say? And the main points that coming out of many reviews is the lack of uniformity in exercises across studies. So it's very hard to compare and establish optimal type and dose of exercise. Exercise is beneficial and encouraged, and cardiopulmonary benefits were definitely highlighted. Monitoring fatigue and adverse events during and after exercise is very important. Personalized exercise programs and aerobic and resistance training at submaximal levels seems to have a positive effect on energy and fatigue to do daily activities. Just about finished. And despite the growing evidence, more research is needed to answer the questions from the Cochrane Review, which was in 2013, which highlights which people would benefit from different types of exercise, what is the most appropriate time to initiate exercise, what degree of disease involvement or disease progression would supersede any benefits to exercise, what is the type of most appropriate type of exercise, what are the most appropriate exercise parameters and protocols, and what occurs at the physiological level. So although there is growing evidence, there's still much work to be done. So I'd just like to say thank you very much for listening, and it's over to Salma. Thank you.
Thank you for that, Karen. That was amazing. Wonderful. All right, so first of all, I would like to thank Gethin and the MNDRA for inviting me to be a part of today's seminar. Today I will be talking about the impact of communication impairment in people with MND, specifically in the early stages of the disease. Now, as we all know, motor neuron disease is a fatal progressive neurodegenerative disorder resulting in deterioration of motor neurons. And in turn, people with MND experience rapidly progressive muscle weakness. People are either diagnosed with bulbar onset MND, where dysarthria or speech impairment is the initial symptom, or spinal onset MND, where upper or lower limb weakness is the initial symptom. Males are more affected than females, and the average survival rate from symptom onset is 2 to 5 years. However, in some cases, death may occur sooner, with an average of 15 to 20 months post-diagnosis. As there is no cure for MND, timely and accurate symptomatic management is required. Now, management of MND is complex and ongoing throughout the course of the disease. With no cure available and a shortened life expectancy, clinical care must be efficient and aimed at managing the symptoms to enhance survival and improve quality of life. Over the course of the disease, people with MND may experience diverse and challenging issues, including, but not limited to, mobility difficulties, respiratory difficulties, fatigue, psychosocial distress, pain, sleep disorders, weakness, spasticity, dysarthria, which is the speech impairment, and dysphagia, which is a swallowing impairment. A combination of pharmaceutical management and targeted interventions using a multidisciplinary team, such as the one Karen had talked about, can be used to manage the varied symptoms of MND. Now, multidisciplinary management of MND involves coordination and integration of specialists across a range of disciplines, including neurologists, respiratory specialists, nurses, psychologists, social workers, occupational therapists, physiotherapists, social workers, dietitians, and speech pathologists. Now, specifically, speech pathologists are a core member of the MDT and play a critical role in helping people with MND maintain the use of swallowing and speech abilities for as long as possible. More specifically, speech pathologists are responsible for timely and accurate provision of assessments and management strategies targeted towards maximizing speech production for as long as possible and introducing appropriate alternative and augmentative communication devices, which enables communication across daily activities such as healthcare, social interactions, communication, participation in the community setting, employment, and expressing one's feelings. Speech pathologists are also responsible for managing diet and fluid modifications, as well as providing strategies to help prevent aspiration, which means that the food or fluid is going into the lungs, which may lead to aspiration pneumonia, as well as ensuring that oral intake is safely maintained. Now, I won't be talking about the dysphagia component of speech pathology management, but we'll specifically be talking about speech deterioration in MND. Now, coming back to what normal speech looks like, speech is comprised of 4 subsystems: your respiratory subsystem, your phonatory subsystem, your articulatory subsystem, and your resonatory subsystem. Now, your respiratory subsystem is the energy source of speech production. From there, when you're expiring air, your phonatory subsystem gets triggered, and that is essentially utilizing energy from the respiratory subsystem to vibrate your vocal cords for phonation. From there, your articulatory subsystem shapes the phonation that's produced from the phonatory subsystem and includes the tongue, the lips, and the jaw, which are all coordinated. Also, your resonatory subsystem is important for clear production of consonants, where your soft palate actually creates a seal with the back of your throat or your posterior pharyngeal wall to ensure that each sound is clear. Now, dysarthria is one of the most common and debilitating features of MND and can have a significant impact on functioning and quality of life. Dysarthria is characterized by difficulty in execution or control of motor speech production that may be attributed to weakness, spasticity, incoordination, involuntary movements, or abnormal muscle tone. As MND progresses, changes to speed, range, tone, accuracy, and/or steadiness of movements in the speech subsystems that I just previously mentioned may contribute to alterations in speech naturalness and intelligibility, and in turn accumulate to loss of functional verbal communication. Now, progressive speech loss, as I previously said, is the most distressing and debilitating symptoms of MND. Dysarthria is an initial symptom of approximately 30% of people with MND. However, majority of people, so approximately 80 to 95% of people with MND, will experience some sort of verbal communication difficulty at some stage during the disease. People with bulbar onset MND are likely to experience speech deterioration prior to diagnosis and access to speech pathology services. Early presentation of dysarthria is either spastic, so that strained kind of voice, or flaccid, of weakness. However, as the disease progresses, it is likely that people with MND will experience a mixed dysarthria, so a mix of the spastic and flaccid dysarthria. Furthermore, early presentation of dysarthria is likely to differ across people with MND due to variability in age at onset, site of onset, and rate of disease progression. Moreover, speech is known to rapidly deteriorate with MND progression, with some people losing speech shortly after being diagnosed with MND. So one study by Cmical in 2018 had done a longitudinal investigation, and they found that majority of people lost functional speech. Majority of people with bulbar onset MND lost functional speech approximately 18 months after their diagnosis, or after, sorry, not their diagnosis, their bulbar symptom onset. As a result, speech pathologists must identify and monitor speech difficulties associated with the impacts across speech subsystems, with the goal of anticipating changes in functional communication early post-diagnosis. Now, while declining speech intelligibility is one of the most prominent difficulties experienced by people with MND as a result of dysarthria, another factor contributing to functional communication decline is reduced communication effectiveness. So how effectively a speaker can communicate in different social situations. In turn, reduced communication effectiveness restricts the ability to participate in daily activities, irrespective of MND variant. Furthermore, self-perception of communication effectiveness is often a key indicator of declining communication ability, especially in people with MND. Reduced ability to use speech or speech loss can therefore negatively impact on social interactions and vocational roles for people with MND. In turn, living a passive or more isolated lifestyle due to the reduced ability to participate in activities of daily living may lead to feelings of frustration, isolation, control issues, and negativity. Therefore, people with MND are likely to experience reduced psychosocial well-being. However, little is known about dysarthria and the impacts on activities of daily living and psychosocial well-being in people with MND from the early stages of the disease. Therefore, an understanding of the impact of dysarthria on psychosocial well-being is needed to inform and optimize health-related quality of life. So in order to do this, my PhD aimed to map the progression of dysarthria across the speech subsystems and identify the impact of dysarthria on daily activities and psychosocial well-being over a one-year period. More specifically, the objectives of my PhD were to provide a comprehensive understanding of dysarthria in people with MND over a one-year period, starting from the early stages of MND after their diagnosis, provide an understanding of the impact of dysarthria on people with MND, and lastly, provide foundational information for future research needed for speech pathology management of people with MND. Now, I haven't gone through all the studies today during the presentation. I will just be targeting the first study, which looks at the impact of dysarthria in the early stages of MND at the very first time point of data collection. Now, the first study of my PhD specifically aimed to explore dysarthria presentation and its impact on communication effectiveness and psychosocial well-being in people recently diagnosed with MND. Due to the complex and rare nature of MND, a cross-sectional multiple case study design was employed to explore similarities and differences of experiences of dysarthria in 7 people. So essentially a cross-sectional multiple case design is where we looked at multiple cases just at one time point. Now, participants were included in the study if they had a recent diagnosis of MND, and we classified that as 6 months or less from the first from diagnosis, and were able to provide informed consent. Individuals who were 7 months post-diagnosis or later presented with a severe cognitive impairment, dementia, or other substantial medical, neurological, or psychiatric disorders, or were not proficient in English, were not eligible to participate. This study did utilize quantitative methods in the form of clinical assessments and patient-reported measures, and qualitative methods in the form of an interview to provide complementary data and to conduct counterpart analysis. Now, 3 theoretical propositions were used to guide the study design and method, including data collection procedures and strategies of data analysis. The 3 propositions were developed by reviewing the literature related to MND, communication decline, and associated psychosocial impacts, through discussions with my supervisory team, and by developing a thorough understanding of the study aim. Now, Proposition 1 suggests communication function and the nature of dysarthria will be highly individual for people with MND in the early stages of MND. Proposition 2 suggests the ability for people with MND to communicate effectively within activities of daily living will be impacted by the presence and severity of dysarthria. And Proposition 3 suggests people with MND who have a more severe dysarthria in the early stages of the disease will have lower psychosocial well-being. Now, data collection occurred over 2 sessions at either participants' homes or at the University of Queensland to reduce fatigability. In order to get a more holistic view of dysarthria and its impact, a number of different tools were utilized in session 1, including the Frenchy Dysarthria Assessment, the ALS Severity Scale Speech Subsystem, the Communication Effectiveness Index, the modified version, Dysarthria Impact Profile, and the Depression Anxiety Stress Scale short form. Session 2 involved an in-depth, semi-structured interview. Using an interview guide during the interview, participants were asked to discuss their experience of MND, communication before and after their MND diagnosis, awareness and adjustment of their communication impairment, impacts their communication impairment had on relationships, and changes to roles and responsibilities as a result of their communication impairment. Descriptive statistical analysis was used to summarize the data for individual participants on the aforementioned clinical or clinician and patient-related assessments. Data analysis of in-depth semi-structured interviews used steps of thematic analysis as outlined by Braun and Clark, and were coded and then put into clusters and categories and subcategories. However, themes were not developed due to the nature of the study. Analyzed data sets were merged, so that's the quantitative and qualitative data sets, and associated with a specific proposition to ensure relevance to the focus of the study was maintained. Proposition 1 was addressed using outcomes from the Frenchy Dysarthria Assessment and ALS Severity Scale. Proposition 2 was addressed using the Frenchy Dysarthria Assessment, the ALS Severity Scale, and the SETI-M, which is the Communication Effectiveness Index. Proposition 3 was addressed using the Depression Anxiety Stress Scale short form and the DIP, which is the Dysarthria Impact Profile. The interview data addressed all propositions. Now, our findings show Proposition 1 was upheld. All cases with bulbar onset MND presented with a dysarthria and changes in functional verbal communication, while both cases with spinal onset MND did not present with a dysarthria or changes in verbal communication. Of the bulbar onset cases, 3 presented with mild dysarthria. However, type of dysarthria varied. 1 case presented with spastic dysarthria, 1 case presented with flaccid dysarthria, and 1 case presented with mixed dysarthria. 2 of the cases with mild dysarthria presented with intelligible speech with repeating on occasion, while another case with mild dysarthria presented with perceived changes. Furthermore, of the bulbar onset cases, 2 cases with mild to moderate dysarthria presented with either a spastic dysarthria or a flaccid dysarthria. However, both required nonverbal communication to support their speech. However, common to all bulbar onset MND cases was the gradual progression of dysarthria in the early stages of the disease. And as previously mentioned, both cases with spinal onset MND did not present with a dysarthria or changes in functional verbal communication. However, all cases with bulbar onset MND and 1 case with spinal onset MND presented and reported laryngeal impairment. Experiences of laryngeal impairment differed across cases, with participants reporting changes in either vocal quality, pitch, or loudness. Furthermore, all cases, including those with limb onset MND, presented with a lingual impairment. Those with mild to moderate dysarthria presented with co-occurring changes to their respiratory system and lip function, in addition to the laryngeal and lingual impairments. Next, our findings show that Proposition 2 was partially upheld. The greatest reduction in communication effectiveness was in the 2 cases with the most severe dysarthria and lowest functional communication scores. However, reductions in communication effectiveness between those with mild dysarthria and cases without dysarthria were not discernibly different. Reduced communication effectiveness in those without dysarthria were caused by reported co-occurring impairments such as hearing impairment, fatigue, and reduced respiratory support. As a consequence of reduced communication effectiveness, participants experienced impacts to socializing, with 1 case reporting that they avoided participation in conversation or socializing with people. Participants also experienced an impact to their vocational roles, with 1 case reporting, "I experienced communication difficulties while lecturing. My colleague is lecturing now. I prepare the slides." And participants also experienced difficulty having their needs met. For example, 1 case was unable to get his food order and reported that she didn't look at me and she didn't understand what I was saying, and she stuffed up the order. Lastly, our study found that Proposition 3 was not upheld, as all cases experienced an impact on their psychosocial well-being, regardless of onset type and dysarthria presence. However, cases with mild to moderate dysarthria reported a greater reduction in overall psychosocial well-being than cases with mild dysarthria. Cases with mild to moderate dysarthria were most impacted by the effect a dysarthria had on them as speakers and the way dysarthria changed their ability to communicate with others. Neither case with mild to moderate dysarthria presented the symptoms of depression, anxiety, or stress. However, 1 case did report feeling miserable, sad, and alone. Cases with mild dysarthria were most impacted by perceptions of others. Cases of mild dysarthria reported symptoms of depression and anxiety, which is linked to the lack of knowledge regarding disease progression. And cases that did not have a dysarthria or impaired verbal functional communication presented with similar reductions in overall psychosocial well-being as those with a mild to moderate dysarthria or the more severe dysarthria of the group. Cases without dysarthria had the most difficulty accepting potential dysarthria due to the role communication had on their life and the fear of speech loss. We also found symptoms of anxiety in cases without dysarthria were related to experiences of changing bodily function. So what does that mean for people with MND and speech pathologists working with people with MND? Well, overall, our findings suggest early referral to speech pathology services and holistic management of dysarthria from the early stages of an MND is vital. In order to provide patient-centered care and holistic management, we suggest that speech pathology assessment and management should incorporate impairment-based assessments, such as the French dysarthria assessment, and functional outcome measures, such as the patient-reported measures, in addition to conversations and education surrounding dysarthria and the impact it may be having on people with MND in the early stages of the disease. We also suggest that comorbidities such as hearing impairment be considered during the early stages of speech pathology management while providing dysarthria management. Now, there are some limitations to the study, which include that we weren't able to capture dysarthria presence and type right at MND symptom onset or right at the diagnosis. Moreover, due to the rapid and debilitating nature of MND, the attrition rates were high for this population. Therefore, another limitation is that we had a low number of participants. Another limitation is that we did not have formal assessment of AAC or include AAC in the study, which is alternative and augmentative communication, which may have informed the outcome measures. Furthermore, while the communication effectiveness index, the modified version, is valuable and provides invaluable insight into the deterioration of communication effectiveness, it is not a validated tool as of yet. While the study and the thesis did not include people with frontal temporal dementia, the assessment protocol did not include a test for cognitive impairments, which is found in 25 to 50% people with MND. Therefore, reduced cognitive ability may have impacted participation in some of the assessments. Lastly, findings from this body of research are limited to people with MND in an urban geographical region, so Southeast Queensland and Northern New South Wales, which may have influenced the study outcomes as well. Therefore, it is suggested that future research investigate communication participation in people with MND by utilizing a validated self-reported outcome measures such as the Communication Participation Item Bank, as well as inclusion of formal evaluation of alternative and augmentative communication, as well as factors that would be impacting the use of alternative and augmentative communication. Lastly, future studies would be further strengthened by inclusion of people with MND from rural and remote areas in Australia. So I would like to end by acknowledging and thanking my supervisors and co-authors, Associate Professor Patria Cornwell, Dr. Anna Rumbach, Dr. Rebecca Nund, and Associate Professor Narina Scrincy for their ongoing support and guidance. I'd also like to give a special thank you to the Prince Charles Hospital Foundation for believing in my work and awarding me with a PhD scholarship. And I'd like to especially thank MND Queensland for their ongoing support. Thank you.
All right, thank you, Salma and Karen. That was an awesome overview of some of the aspects of allied health research in MND treatment. I really had no idea, and I should do probably, Salma, how complex speech is, that the four different parts to it. I've never really thought about it in that way, but it all makes perfect sense. So we've got a few questions lined up. Just a first question for Karen. If you come back on camera, you've got if you're still there, hopefully. I'll start off with a question for Salma then, while we're just waiting for Karen to come back. So you were talking there about, you're mentioning about this was a city-based study. Could this study be conducted remotely, these type of studies for sort of speech pathology, speech quality? Could that sort of expand your reach quite simply?
Yeah, I think the biggest issue I had, I guess, with the PhD, you're on a limited timeline, but also recruitment was quite challenging because getting that that confirmation of diagnosis is quite a quite a hard time, and we were trying to get in right at that point. So also just respecting the fact that the participants were going through quite a bit at the time that I was trying to recruit.
And sort of just leading on to that question a bit for Karen. So has the sort of advent of sort of telehealth, remote access, how much of a difference can that make to the multidisciplinary treatment? I mean, do patients still need to come into the clinic, or can you pretty much monitor their disease almost completely in their care remotely, or do they still need to come in for certain sort of analyses and treatments, etc.?
Yeah, that's a good question. So I think I think telehealth can be a very good option for those that are finding it very difficult to get out of the home, and to sort of keep monitoring and touching base with them. But you learn a lot from actually people coming into a clinic space or actually going out to that person's home. So because it's very important to check on their environment where they're living, you can learn a lot from that. And also the coming into the clinic where you can actually all assess, and then that's when the case conference and the goal setting can work quite well. I think the current state of service delivery at the moment with the NDIS, we do have a lot more practitioners working in isolation rather than working as a team. So I think having an opportunity to sort of work together and have those communications, which is whether it's a team that goes, can do the telehealth all together, or actually coming into the clinic space. I think it's really important way of connecting and getting different perspectives across the team.
And thinking about that multidisciplinary approach, is there a can you have I guess you call it almost a semi-multidisciplinary approach? Perhaps certainly for in the regional areas, you may only have a couple of the disciplines to hand as such. And does that still work? Do you still get a benefit if you've, say, 2 or 3 different allied health disciplines in one space, and perhaps then you have to outsource a couple of the other aspects of the care? Is that still of benefit?
Yes, yeah, I mean it is, but it's also really good if we can actually, if some healthcare professionals who have not got a very limited experience in MND, that there is an opportunity to connect with more specialist teams as well. And I think that's been a discussion that Allied Health have had, and this is where some of this, the clinic came about, was the discussions of around connecting up with teams, healthcare professionals working together and learning from each other, that incidental conversations. And I know you know, we've also got My Age Care as a way of you know, of funding. So some people work, get their therapy through the hospital systems or public health with My Age Care as well. So you've got, you know, depending on who is there, but if there is an opportunity to actually connect with specialist teams, I think that's really important.
And a question going back to Salma here. So can you do some of your studies by recording people's speech and then doing sort of, I guess, post hoc analysis of their speech? In speech pathology, are there benefits to be obtained from such an approach?
Yeah, absolutely. So the thing with protocol is that, for instance, we need to make sure that if you are recording your speech, it's at a certain distance, and that's yeah, there's a few procedural things that go along with it, but yeah, you can absolutely have people record their speech using the procedures and then bringing that in and then analyzing it. I think the biggest thing that we were trying to do with my PG specifically, and mine is it uses clinical assessment, so that's the difference. You do have other studies that use acoustic measures or kinematic measures, so different types of tools. So specifically for me, we were looking at how clinical measures can be used now in real time while we're waiting for a cure. So in terms of recording speech, you could use probably the speech recordings for acoustic analysis, which is also quite a valid tool within the realm of speech pathology.
And there's a question here. How can speech therapists assist people with MND if their professional assistance is sought soon after diagnosis with a person with bulbar? Do doing the speech therapy exercises make much difference to the quality of communication? How much sort of, I guess, longer term, perhaps?
Yeah, so with speech pathology, we always say get early referrals. So number one, you're getting that baseline assessment so that you can monitor progression. So that's where you have the follow-up assessments every 2 to 3 months, like Karen had mentioned for the multidisciplinary care. But number two, you can actually start talking about voice banking or message banking early on and getting that completed with your clients so that they have the opportunity to record their voice while their speech is still clear. You could also talk to them about certain things like a digital legacy, which is a free application online while their speech is clear. So those are the things that you want to start on early. It's also about giving them education about their speech and swallowing. So that's really important because if we think about it, we're treating only one small aspect of a really big whole. And so just having that continuous education, allowing people with MND to consolidate what you're saying from a really early stage is really important for compliance with potentially introducing alternative and augmentative communication as disease progression occurs. So that would be my recommendation in that regard. In terms of exercises, aside from EMST, so that's expiratory muscle strength training, which is still an early program, and I know of Emily Plowman mainly in the States who's doing research on that. I'm sure there's other researchers out there. It is actually contraindicated for people with MND at the moment, specifically for speech and swallowing exercises. So that is actually an area that would be great to research. However, there have been single case studies where they showed that it's actually made the person with MND worse faster. So I wouldn't recommend any other exercises in terms of speech and swallowing.
Cool. Thank you, Selma. A question for Karen, I guess. So with the idea of sort of exercise dosing, it always seems to be a challenge as how you can actually work out how much exercise someone can do without compromising their other aspects of their health, I guess. And do you know if there's people perhaps here or overseas who've doing a little more work on those exercise prescriptions for people perhaps with slower progressing disease as well?
From the literature that sort of I reviewed, there seems to be this type of work is happening across the world. So there's lots of pockets of this type of research going on. But from what seems to be the issue is that there is the design of the research is not consistent, and this is where the reviewing of the different literature makes it hard to sort of compare results to actually work out. But what does seem to be consistent is that you know, exercise is beneficial, but it, you know, and they're looking at more the aerobic and as I already mentioned, sort of the submaximal resistance training, but it's also the impact is having more on cardiopulmonary benefits there. And then also if people are using NIV, the non-invasive ventilation as well, there's sort of the dual effects from both those approaches, exercises and that at the same time. But there does there's talk about slowing down disease progression. But the thing is, if people are less fatigued and have got more endurance, they're more able to do activities of daily living. And as Salma mentioned, you know, like all part of that is actually speech as well, and communication. And so it's not just, you know, walking around the house. There's, you know, there's a lot involved in that. So having that cardiopulmonary benefits could actually help with the communication side of things too.
Yeah, that makes a lot of sense. Also, go back to your work you're doing with the Central Coast Clinic. Obviously, regional care is a huge issue in Australia. Is there kind of a, I mean, this study may well tell you that, is there a kind of an optimal or a minimum number of patients you need to be able to justify a multidisciplinary care, or can you sort of perhaps share those share the sort of facilities with other maybe neurodegenerative diseases, you know, like the allied health practitioners? Could they cross over several different disease areas to provide multidisciplinary care across a range of different conditions? Has that been done, or is that done? Is that standard practice?
So initially, to go back a little bit on the Central Coast, prior to the services were changed a lot. So prior to the NDIS, we used to run within health and the public health system, we run a community-based neuroprogressive neuro condition team, multidisciplinary team. So there was MS, Parkinson's, and various others, and MND. So this was a team that was set up, and we went out into the community and we monitored people through the progression of their disease. And then with the implementation of the NDIS, that team was disbanded, and the whole setup of the teams were changed. So there's definitely, we're trying really hard to link ourselves in with the allied health team that works within the health system, because they do look after the majority of people in my age care, funded people with MND. So we really try to link in with them. They're the ones that also do the respiratory management. So if we've got acute respiratory care requirements, then they can help us support that. So definitely they are looking at it within health. They're looking at this model to try and see if we can sort of adapt it to other progressive conditions. And currently this model is not being, this clinic is not being run within a public health system. So it's run privately. And the reason it's 3 times a year is because of the capacity of the healthcare professionals to be able to do this more often. And through word of mouth, the clinics are getting bigger, and more people are keen to attend. But it's just the capacity. So that's why the evaluation is really important, to work all these logistics out, what is needed, what the resources are, how can we sustain this, how can we fund this this model of care, and how can we work with health to maybe work more together.
Yeah, you're completely right. All the evaluations of these research programs is absolutely critical to be able to take sort of evidence-based proposals to government or funding bodies to say justify it. It's something I think perhaps people don't understand how important it is. You know, to prize money out of people, you really got to show them that they're getting value. They'll get value for that money. Yeah. So I think we're good with the questions now. We're a bit over time anyway, so we'll have to wrap up for this evening. Just like to thank you both again, and to thank all our viewers as well for dialing in tonight. I think it's been a fantastic, the real care, I guess, at the right at the coalface. For everyone listening, the session has been recorded, so everyone will get a link to the recording. So please feel free to share that with your friends and community members if they're interested as well. Everyone registered will get that as well. And also these will be up, there'll be links to this on our website as well with the other state, and there you'll also find the other state of play sessions if you're new to this and haven't had a chance to watch them before. So that all just remains me to say good night to everyone, and again thank you to our fabulous presenters. So good night everyone.
Good night. Thank you.
Thank you.